introduce her. Let me get out of mine so that she can have the opportunity to get her slides up. Dr. Rebecca Johnson, PhD, ABPP, is a pediatric psychologist at Children's Mercy, Kansas City. She serves as the chief of the section of pediatric psychology within the Division of Developmental and Behavioral Health and is a professor of pediatrics at the University of Missouri, Kansas City. She received her PhD in clinical psychology. I'm sorry, I already read that. I'm sorry. Her clinical practice is focused on the mental and behavioral health of children with chronic medical conditions, including chronic kidney disease, short bowel syndrome, intestinal failure, and cystic fibrosis. Her research interests include examining the effects of chronic disease on neurocognitive and psychosocial functioning and promoting the quality of life of children and families navigating health conditions. So it is really an honor to introduce someone that I worked with for years and absolutely loved what she did to help our family. So thank you, Rebecca, for being here.
Hi, Beth. Thank you so much. That was very nice. And I didn't realize I had to share my own slides, so give me 1 second and I will do that. All right. And sorry, I think some of the Zoom things are getting in the way of me being able to go to the slideshow.
You have share your screen up?
Yeah, can you see my slides right now?
Yes.
Okay, I'm just trying to get it into the slide. There we go. Everything look okay?
Yes.
All right, good, good. Well, thank you again, Beth, for that nice introduction, and I've really enjoyed all of the speakers today. I'm very glad to be here with all of you this afternoon. And as Beth said, I am a pediatric psychologist at Children's Mercy, and I've spent my career working with children and families where the children have chronic health conditions. I do not have any disclosures. So my objectives today, and I'm going to get rid of, there we go. My objectives today are to describe what we know about the quality of life for children and teens on HPN, describe some of the psychosocial challenges of intestinal failure that may impact quality of life. A lot of that is based on my clinical experience with youth who have intestinal failure. And then to understand how parenting a child receiving HPN may impact parent and caregiver quality of life, as well as just kind of the health and well-being of the larger family. And I think it's important to start by noting that, you know, when we give talks like this, you tend to have to talk to some extent in generalities. When we talk about the research or review the research, we're talking about averages or medians, you know, kind of how a group of people are affected. But it's really important to remember that every family has their own unique experiences. They come to the table with different resources and support. And so there's a lot of variability. And we also just don't have a lot of research about quality of life for children and youth and young adults who are on HPN. But I will talk about what we do know. All right. There we go. I wanted to start out just with a definition of what health-related quality of life is, and we sometimes abbreviate it HRQOL or QOL. It is a multidimensional concept that includes domains related to physical, mental, emotional, and social functioning. And it's a person's perceived mental and physical health over time. A related concept to quality of life is well-being, which assesses the positive aspects of a person's life, including positive emotions and their life satisfaction. And more research is paying attention to the more positive aspects of health and emotional and social growth. That's really been something that has developed and become more common over the last decade or so. That rather than just focusing on kind of the negative effects of a health condition or focusing on, pain or anxiety, that we also really want to assess aspects of well-being. I'm a co-investigator on a longitudinal study of children who have chronic kidney disease, and a couple of years ago we shifted our the way that we assess quality of life from just asking more questions about psychopathology, anxiety, depressive symptoms, and really trying to understand more about, well, what are friendships like for kids with CKD? What types of social supports do they have? When do they feel like they have good self-efficacy? And so really trying to look at that broader picture of a child or a family and understand those aspects as well. All right, so I will start by talking about the quality of life, what we know about quality of life for children and teens who have intestinal failure or on PN. And as I mentioned earlier, the research is somewhat limited when we're talking about looking at larger groups. And when I think about Dr. Mercer's final comments about how quality of life is really improving rapidly for children who have intestinal failure, I think that's a really important take-home point, because there's always a lag in the research. And so, even what I'm describing now, we're probably seeing gains compared to when these children were assessed. So I'm going to start by talking about how parents rate child quality of life. And in several studies, parents of children with intestinal failure have reported lower quality of life for their children than parents do in normative samples. So parents of generally healthy kids who don't have chronic conditions. And they've reported impacts on children's quality of life across ages and across domains of quality of life. So both physical quality of life as well as things like emotional quality of life. And I should probably mention that probably some of you have filled out rating scales related to quality of life. The PedsQL is one that's used pretty widely. There are some patient outcome measures called the PROMIS measures that are being used more and more often. So this may be something that you've been asked to do when you're in a medical visit with your child. I know in our kidney center we ask families to do this every 6 months or so, and we ask them to do it a couple times a year in the intestinal failure multidisciplinary clinic as well. When we look at children's self-report of their quality of life, we find that younger children tend to report generally good quality of life across the emotional, social, and school functioning domains. So when we ask them about things like, are you keeping up with your schoolwork? Are you able to focus in school? Are you able to run, lift things that are heavy, do chores around the house? They tend to report, pretty good quality of life. When we look at more of those physical functioning items, those are where we see some differences when children are young, and they rate their physical quality of life as a little bit lower than children who are otherwise healthy. In one study, the differences were really limited to dependency for help with day-to-day activities, and were not related. There were no differences in terms of school attendance, fatigue, pain, or body image. Once we get into kids who are a little bit older, so children who are older than 11 years, they tend to report more impact to their quality of life. So if you ask them about school and their social functioning, they tend to start to have differences in how they rate their quality of life compared to their healthy peers. There was a recent longitudinal study looking at quality of life, and this was done in the Netherlands, and they followed 35 patients with intestinal failure who were receiving HPN. If the patients were less than 8 years old, the parents rated quality of life, and if they were 8 or older, the children provided their own self-reports. They surveyed these kids every 6 months, and for those 35 patients, they collected 272 data points. So that's a pretty decent amount of data for a longitudinal study. And at the last survey they did with the kids, the median length of time on HPN was 5.3 years. So in this study, they did report lower quality of life than the general population, and parents reported younger children had more fatigue than the general population. but the quality of life didn't decline over time. So length of time on HPN did not predict quality of life. It tended to be pretty stable over time. In addition to more what we think about as quantitative studies where we have rating scales and averages and we run statistics, have also been a very small number of qualitative studies. And this is where researchers sit down with participants, with kids or their parents, and they interview them. They record everything that they say, and then they go back later and they code those kind of narrative reports, and they look for common themes that come up. And so in this study, the researchers interviewed children ages 7 to 17 who were receiving HPN, and they found that there were 4 common themes when they asked these children and teenagers to talk about their experience with HPN. One theme was the impact of living with the illness, so feeling more dependence on their parents, feeling stressed when there were complications or unexpected developments, incontinence, and having higher levels of fatigue than they would like. They also talked about some of the restrictions on their life, such as limitations on their physical activity, sometimes just wanting a night off from having to do all of their cares, having restrictions on eating, and missing school. They also talked about how being on HPN impacted them socially and their identity. So not knowing, when or how, or trying to figure out how to disclose medical information to peers, worrying about the effect on their siblings, having to tolerate bullying and teasing and navigating that. And then that desire to be more similar to their peers or to be quote unquote normal. In addition to those themes, they also talked about resiliency and how they've learned to cope and adapt. So their interviews were not, all negative or sad. A lot of these kids also identified ways that they have benefited from living with or adapting to having a chronic health condition, whether that was a greater appreciation for certain things in their life, or development of empathy, or development of maturity or mastery over some of those tasks. And then I wanted to talk a little bit about, when I worked with our intestinal rehabilitation team at Children's Mercy, a lot of the kids I worked with were younger kids, but I did have the opportunity to work with some school age and teenage kids. And I just wanted to talk a little bit about some of the issues that often came up that I talked with them about that were related to quality of life. One of them was activity restrictions. So not for all kids, but for some kids, being restricted from certain sports was something that was distressing to them and that they had to learn to adjust to. Swimming was another thing. I think for a lot of adults, it's just one in a list of many activities, but for kids, swimming is a big deal, or it can be a very big deal. It's what they do in the summer. It's what you do when you go to hotels. It's what you do on special occasions sometimes. And so swimming or not being able to swim could be a really significant issue for them. Difficulty attending sleepovers for a variety of reasons, whether that was incontinence or just the medical care that they required or just logistics of making it happen. And school absences that impacted academic performance, which again adds school stress, social development, and self-efficacy. Some of the things that I would work with them on were helping them to find that one thing that was important to them. So maybe it was something that they were really good at. Maybe it was just something that they really enjoyed, and it might have been a sport or a hobby or a club or an activity. But just kind of working with that family to figure out what that might be, and then making sure that it became a priority and that everyone was committed to some amount of time and resources to make that happen. Working with your medical team to identify safe or safer sports that they might be able to do if that is something that's really important to them. Problem solving how to make special events work. So whether that's a prom or a dance or a camp out or something, how do we change their thinking from these are things I can do. I can't ever do these things, to, okay, how could we make this work? Can we brainstorm how we might be able to make this work? And then I think it was actually Beth who would recommend putting together a go bag with needed supplies. If you are parents of teenagers, you know that sometimes their plans come up very quickly and they develop very quickly. And so, being a little bit prepared for being able to go with a friend or go on an outing can be really helpful. Eating was another thing that came up often in my clinical practice, and it came up in terms of parents feeling the struggles parents were having with teenagers or kids, and then it also came up for the children and teenagers themselves. And as Dr. Mercer kind of touched on this a little bit earlier in his talk. I'm definitely not talking about kind of those classic eating disorders. That's not what I'm talking about, but problems with eating tend to be very common with kids, especially if they were affected early in life by intestinal failure. They have a lack of those positive oral feeding experiences. They might have abnormal hunger patterns. They may have had missed developmental windows, and there might be a lot of challenging parent-child interactions. They also tend to have less than full participation in family meal times, and it's really important to think about how meals have a lot of cultural and social aspects. The food can be the centerpiece of celebrations and milestones. I worked with a teenager who was really distressed about not being able to eat and enjoy food, and she told me, eating is life, and that was just a really important aspect of life to her. And so it caused her a lot of distress not to be able to eat in the way that she wanted to eat. And then, of course, you can have things like supplements, which are aversive, or just children and teens and many people having strong preferences about what they will or will not eat. And so, a lot of times it was about working with them to create doable nutrition goals. A really important thing is that, especially as they get older and they're teenagers, we need them to self-report sometimes what they're eating. And so having that really open and non-judgmental communication is really key. I worked with a teenager once who had been eating food he wasn't supposed to when he was at school. And the parents had, a really big reaction to that. And then we kind of he just shut down after that. It was really hard to have that dialogue with him and to learn about what he was doing when he wasn't around his parents. Behavioral strategies can be really helpful, encouraging participation in the social and cultural aspects of meals, and even some mindful eating, really savoring and enjoying what can be eaten. And then body image is another thing that comes up, especially as children start to get older, and it's something that can affect their perception of their quality of life. Looking different from the norm can be very distressing. There's kind of that comfort and conformity. And even sometimes when teenagers, in the ways that they're trying to be different, are still kind of very carefully calibrated to be within, what's perceived as acceptable in their peer groups. Special events can heighten distress. Some teenagers, especially some of the female teenagers that I worked with, had concerns about future partners and, will anyone want me? Things like that. And there's not a lot of research on this. I kind of threw this in here because when I looked for some literature on body image, there was very little. But there was one study that looked at kids with cystic fibrosis, and found that those who had G tubes, had feeding tubes, had reported less satisfaction with their body image. I think it's really important to acknowledge and validate those concerns about body image. I think our default can be, just to encourage them to see it as, a positive, or you're resilient, and that can be helpful sometimes to see it as like a battle scar or something like that. But sometimes they really just need people to validate that, yeah, it's not ideal and it's not what you would have wanted. And I understand that it's upsetting for you. Again, problem solving how they can attend events, being aware that if they're not adherent, that sometimes there's something behind that in terms of concerns about their body image or their desire to be quote unquote normal. finding opportunities for support. And then I think it's important to think about, at what point is it time to kind of to broach topics around sexuality and reproductive issues, because sometimes kids get ideas in their head, and I would talk to them, and what they were thinking was just not accurate. And so, being open, and whether that's someone on the medical team or a parent or a coordinator, but it's someone being able to give them opportunities to ask questions and get good information about those issues. All right, so now I want to switch gears a little bit and talk about quality of life for caregivers and the family. And so a lot of these studies have been done with caregivers of children who have short bowel syndrome, but some of them are a little bit more broad and look at PN more broadly. But in general, when we look at caregiver and family quality of life, parents tend to report low quality of life for themselves across domains, and they tend to report fairly high rates of worry about their child and their child's medical condition. Parent quality of life tends to improve somewhat as children get older, but it's still not at the same levels of parents of kids who are generally healthy. Family quality of life also tends to be rated as impaired. Daily activities are often impacted, and family relationships can be impacted as well. Parents of children on PN report higher levels of marital stress compared to parents of children with cancer. So, I think the highlight there is that this can be a really challenging medical condition to manage. And there's just a lot of day-to-day impact, and that impacts family relationships. Mothers tend to report less satisfaction than fathers in the domains of work, inner life, and freedom, probably because they're more often the primary caregiver, although not always, and that's definitely something that's evolving. And then one study found less impact on health-related quality of life. So these parents tended to report pretty decent quality of life, but higher rates of distress and more symptoms of depression for the mothers. When we look at parenting stress, there's a very, very small literature on this, but parents of children with intestinal failure have reported pretty high levels of parenting stress. This has been shown to be associated with chronic abdominal pain for their children and children who stool more than 3 times per day. And then mothers of children on home PN, similarly to what we saw earlier, report higher symptoms of depression. Not necessarily clinical depression, but they just tend to report more symptoms. And then the caregiver's perception of treatment burden is associated with their distress and anxiety. So if they perceive, if the treatment burden as that gets higher, it tends to be harder to cope with, which is not surprising at all. And then I wanted to talk just a little bit about a qualitative study. So similarly to how we kind of move from that quantitative to qualitative with kids, I wanted to do that for parents as well. And this is actually a study that was done with parents of children with chronic kidney disease, but there are a lot of similarities, and they're both fairly time-consuming and complex conditions. And I really liked this study a lot because, again, they sat down with parents and interviewed them about their experiences and looked for themes across parents. And one of the themes was absorbing the clinical environment. So having to confront the diagnosis initially, having to parent their child through invasive procedures, frustration when the care that they received in the hospital or on the outpatient side was inconsistent across providers or across clinics, feeling like they sometimes would lose ownership of their child, and then that worry about jeopardizing relationships with staff. So there's a power differential when you're in the hospital and having to navigate that, and wanting to be assertive for your child, but also trying to maintain those relationships was stressful. And so this was one kind of theme of things, that absorption of that clinical environment, that really impacted their functioning and their quality of life. A second theme was the medicalization of parenting. So, one of the really great things about some of these chronic conditions is that we've developed ways to keep these children alive. We've developed ways to treat their conditions, ways to improve potentially, their quality of life. But a lot of that often falls on parents to actually implement and do all of these treatments and this regimen day to day. And in the United States, at least, we haven't prioritized home health care and the resources that parents and families might need to be able to do this. And so, that consuming routine, all that medical management, having to experience all of those invasive procedures with their children and that psychological trauma. And then the third theme was just the disruption of I don't know why I said that. It's not it's a huge thing. The disruption of family norms. So feeling torn between your child and the siblings who are at home, if you're admitted with your child and there are siblings at home, household and financial stress, not being able to socialize, not having time for that. And for some of the, especially for younger parents who are, in the middle of making a family, just that disruption of family planning, like, are you able to have another baby? It changes your timeline potentially. And then I wanted to talk a little bit about, I know I'm getting close to time, so I will try to maybe skip a couple of slides. But I also want to talk a little bit about things that parents shared with me as I worked with them in that clinical setting, things that impacted their quality of life and, how in their management of their child's care. So that some of that anticipatory anxiety regarding child's weight, I don't think medical teams are always aware of the anxiety that families or children feel as they approach those clinic visits and are going to be weighed. And a lot of decisions are sometimes made off of whether the child's gained weight or not, or lost weight and things like that. Fear of admissions and distress when admissions are necessary. Being admitted to the hospital is a very stressful experience. And it's hard sometimes not to feel distress about that and worry about whether that's going to be necessary. Transportation problems, long distances, overall, some of these conditions are very rare. And so oftentimes families have to travel a long ways. Having appointments in multiple clinics that don't coordinate those appointments, having to get labs, challenges of shared decision making. So I talked a little bit about this earlier, but just those challenges of having to work with other people who get to have a say and that collaborative process, and whether that goes well or not is a huge deal. Tolerating home health care. A lot of times families recognize that they needed help from extended family or home health care, but that doesn't mean it's not unpleasant or unwanted at times, and just having to tolerate that. Communicating with extended family, sometimes grandparents would have an opinion as well, and it may not be the same, so that could be challenging. Fatigue, just feeling tired all the time. Social isolation, and then not being able to get their own medical and mental health care needs met simply because there's not time or the resources weren't there. That could be a challenge. And then just, on top of all of the typical parenting challenge, and I think I've already alluded to some of these, but just kind of those additional parenting challenges that come along with having a child who has intestinal failure. And then I think if we want to stay on track, Beth, I can skip over this part. I was going to just talk a little bit about data from our program on family quality of life using the family impact module. And again, these were mostly younger children and mostly kids with short bowel syndrome and you can see about 40% were on PN. And this was the PedsQL family impact module. I think the quick take-home points are that family quality of life was really impacted. So the PedsQL goes from 0 to 100, but once you start hitting the low 70s and the 60s, that's a pretty significant finding. And you can see that the families of parents on PN tended to report, if you look at daily impact on daily activities, there was a significant difference, as well as caregiver social functioning and being able to socialize, and some of those other measures as well. And then just to kind of put that in context, because those numbers don't really mean a whole lot when I throw them up on the screen, the parents of children on PN reported, fairly similar family quality of life to the parents of children with nephrotic syndrome, which is a fairly significant treatment heavy burden type of kidney disease, and medically fragile children at home. So children at home who maybe have trachs or who have severe developmental delays, things like that. So again, definitely some significant impact. And then my take-home points, parents report impaired quality of life for children on HPN. Children tend to self-report, really limit it to physical quality of life when they're young. They perceive more impact to their quality of life in additional domains as they get older, but they also report perceived benefits. They report being resilient in many ways and different ways that they're emotionally, mature and growth. So it's not an all bad news situation. I think another take-home point is that parenting a child on HPN is challenging, and parents definitely report that it impacts their quality of life, and they can at times experience high levels of parenting stress. But it's also really important to recognize that families can be very resilient. Families can do hard things. Parents do hard things all the time. And I think we just want to be cognizant of that quality of life so we can make sure that whenever possible, we're mobilizing the resources and the support that they need to be successful and to really experience that well-being that I talked about at the very beginning of the talk. All right, and those are my references, and that is the end.